We'll go ahead and get started. Today's topic is going to be diuresis renography. And those of us who treat children with urological concerns know that hydronephrosis comes in all different types of presentations. Historically, symptomatic presentations were the most common with children presenting with abdominal pain, abdominal masses, and urinary tract infections. Increasingly, the presentation became one of an incidental finding on imaging. And with the advent of prenatal sonography in the 1970s, we began detecting these problems in very young children. There are a variety of causes of hydronephrosis. The principal cause would be a primary non-obstructive hydronephrosis, which is something that we see in most children who present to our practice, but certainly vesicoureteral reflux obstruction at any level of the ureter, be it at the UP junction, UV junction, or even urethral obstruction. Neuropathic bladder can also present with hydronephrosis. And then there are a few diagnoses such as dysplasias and prune belly syndrome that are seen with hydronephrosis as well. The first study looking at diuresis renography came from our institution in 1985, and Evan Cass standardized the what is now classical three-tiered grading system for obstruction based upon an experience of more than 200 older children who presented with symptoms. And what he did was pair the diuresis half-time with findings on Whitaker's study, and identified that children who presented with half-times of less than 15 minutes were not obstructed based on the Whitaker findings. Those who had T1/2s of 15 to 20 minutes were felt to be indeterminate, and those who had half-times greater than 20 minutes were felt to be obstructed. And so this became the industry standard at the time. And because one could operate on children with a high likelihood of success, folks felt that since an operation was safe and a result was good, then why not perform early correction as soon as the diagnosis could be established, which meant that when children presented in early infancy and you diagnosed significant hydronephrosis with prolonged half-times, then one should just go ahead and fix it. But there were a few who actually began to question this dogma. In an early paper on the subject by Mr. Philip Ransley that was published in 1990, what he did was to take a group of children who were born with all grades of hydronephrosis, and he segregated them based on the differential renal function. So there were the majority with very good function, a intermediate group of patients who had 20 to 40% differential renal function, and then a small group of patients who had a very poor renal function. And he thought that what he would do is to see what the natural history of these three groups might be. And what was very interesting was that certainly the ones that had very poor function went early on to surgical intervention. The 2/3 of those actually ended up having nephrectomies for extremely poor function, while a minority of those actually underwent pyeloplasty, despite the fact that the function was between 10 and 20%. The intermediate group, many of those children actually went on to be operated on because, of course, their renal function was less than 40%. But there were a few of those cases that actually escaped intervention despite the fact that they had met criteria because of, quote, clerical errors. And Mr. Ransley was quite intrigued by the fact that these, quote, lost to follow-up cases might come back years later with actually a stable renal function and resolving hydronephrosis. In the broader category of patients who actually had fairly good renal function, the likelihood of progressing to pyeloplasty was actually quite small, suggesting that for the majority of patients with fairly significant hydronephrosis and good renal function, pyeloplasty was not necessarily inevitable. These data were then followed up actually in the same journal, in the same issue of the Journal of Urology by Dr. Holmesy, who similarly found that in children with intermediate or indeterminate half times, the likelihood of going on to delayed repair was actually only approximately 20%. So what we needed was to understand better whether this phenomenon of partial obstruction was something transient, and we needed a test to be able to identify whether restriction to urine flow that, if left untreated, might cause progressive loss of renal function. We needed a test that could reliably predict deterioration of renal function, and we had that test already. In the diuresis renal scan, which we believe actually can predict which patients deserve to have repair and which do not. The reliability of diuresis renography is dependent upon controlling for a variety of factors. These factors include the state of hydration, the state of bladder filling, the diuretic dose and the timing of that dose, the position of the patient, how one collects the data, the region of interest, and the interpretation of those results. Things that cannot be controlled are the grade of hydronephrosis and the patient's renal function. So let's go through each of these in turn. First, the state of hydration. The tracer that we commonly use is technetium, and it is joined to mercaptotriacetyl triglycine, or MAG3. And it is partially secreted and partially tubularly bound. The transit of this tracer through the renal parenchyma is dependent upon renal blood flow to some extent. And one can imagine where a patient that is dehydrated would have decreased transit time and therefore might seem to have a prolonged drainage half time. Next, bladder filling. It is not a far leap of logic to understand how a distended bladder might impair ureteral drainage. And if the bladder is over-distended during the drainage phase of the film, one can actually see good examples of prolonged drainage simply because of the filled bladder. In this diuresis scan, we begin over here with the early cortical phase, and you can see here that throughout the transition to the drainage portion, both of the kidneys seem to drain reasonably well. The right kidney is on this side, and the left is on this side, and you can certainly see where the right kidney is the hydronephrotic one, and is the one that we are being asked to examine. At this point in the drainage, the nuclear radiologist sees that there is early spontaneous drainage of tracer and administers the Lasix. So I have you now look down here at the red portion of the scan. The Lasix is administered, and there is a fairly quick drop in the amount of tracer in the collecting system. If you look over here on the graph, that corresponds to the red arrow and the yellow arrow down here. Keeping your eye on the diuresis half time, you see that actually the amount of tracer in the upper portion of the collecting system actually increases over time. And that is commensurate with what's happening actually at the level of the bladder, which is also filling, and it becomes more filled and more distended by comparison to earlier on in the study. In this example, which is much like the first, the nuclear radiologist has realized that between the red and the yellow portions of the drainage curve, there actually has been distension of the bladder. And they actually mark here emptying of the bladder, either by catheterization or by spontaneous voiding on the examination table. And you can see here how simply emptying the bladder at this point in the drainage curve actually promotes further drainage, which is quite brisk. Next, the diuretic dose and the timing of administration of that diuresis is critical. There have been a couple of different protocols which have been discussed with regards to the timing of administration of furosemide with respect to the timing of the dose of the MAG3. The protocols being either administration of the Lasix prior to or during the dose of MAG-scan or following the dose of MAG-scan. The final thing that we'll discuss is positioning of the patient, and this is perhaps one of the most critical things, but it actually is, I think, in tandem with the timing of the dose of the diuretic, which we actually get most of our information between this and between this. And we have a couple of cases actually that we'll discuss today that will elucidate these different points. The key, I think, point for us performing the study at Children's National is that we believe that there is no better time to challenge the collecting system with diuretic than when the collecting system is already maximally filled. So this actually requires very close scrutiny of performance of the examination by a nuclear medicine physician, who then decides when that system is maximally filled, and that would be the appropriate time to provide the furosemide. Generally, it is administered approximately 20 to 30 minutes after injection of the tracer, which is about the time that it takes to maximally distend a hydronephrotic collecting system in most patients. In this example here, I want to highlight two completely different cases. First, patient in this group A. Second, the patient in this grouping B. Approximately 30 minutes after the injection of tracer, the patient has actually now maximally distended the collecting system, and you can see that the system is much more full than this, and it is at this time that the furosemide is injected. We then follow drainage for approximately 30 minutes after to see what happens with the tracer, and this left kidney drains very little during that time. Once we have observed the system for approximately 30 minutes, we then place the patient in the upright position. So at the beginning of upright or gravity-assisted drainage, the patient has this still-filled collecting system, which corresponds to this section of the drainage curve right here. And after approximately 15 to 20 minutes of being upright, the patient is then imaged once more, and we can see here that there is only 11% of the originally extant drainage, the extant tracer is now drained. By comparison, this second patient with right-sided hydronephrosis and a very similar looking scan to the first one, when placed in the upright position, demonstrates very brisk gravity-assisted drainage. And now 92% of the tracer has drained in this patient. So despite the fact that both exams were performed in exactly the same way, with the same timing of Lasix administration and the same T1/2 grafts, you actually see very different gravity-assisted drainage in both of these patients, and we would suggest that this patient is obstructed and this patient is not. The next thing, which is important to realize, is that it is not sufficient simply to draw some circle around the dilated system and expect to receive accurate results. Panel A and panel B are the same patient with two different regions of interest. This patient was actually being evaluated for hydronephrosis that crossed the midline. And in the first circumstance, the region of interest was drawn, which was too small and did not actually include the entire dilated renal pelvis, as you can see here. It's very difficult to tell. I apologize. You'll have to sort of take my word for it that this little green curve goes here, and then you have renal pelvis, which is actually outside of that region of interest. By comparison, the region of interest on this side is much more complete and actually encircles the entire hydronephrotic collecting system. Notice here how an improper region of interest results in a fairly prompt washout curve, while the correct region of interest demonstrates clinically significant obstruction, which corresponds to the degree of hydronephrosis that we're seeing. So how do we interpret a diuresis renogram? Well, first, we want to look for cortical retention. Second, what is the differential renal function? What is the diuresis half time? What is the shape of the drainage curve as an indicator of the dynamic process which we are measuring, which is flow across the ureteropelvic junction? What is the clearance at 30 minutes? And looking for gravity-assisted drainage. Cortical retention. What happens with acute obstruction is that renal blood flow actually goes down quite dramatically. During this phase, there can be very prompt accumulation of the tracer in the renal cortex, but because renal blood flow cannot take this tracer down through the distal portion of the nephron where it is secreted, then it remains in the cortex. Any of us who have seen cases of nephrograms on a CT scan or on an intravenous pyelogram, for instance, in patients presenting with acute obstruction from a stone, can quite confidently say that a nephrogram is a sign of obstruction, and this is basically the correlate to a nephrogram, but in a diuresis mag scan. And when we see this, we actually know that the kidney probably has a fairly good function, but you literally cannot actually measure the function accurately at this time. In this case, this patient presented with a fairly dilated renal pelvis by CT scan, and there actually was a diminished flow on that side, and you can tell by comparing it to the normal contralateral kidney on the right side. And we had this patient actually come fairly quickly for a mag scan. And what's interesting is that one can see that the cortical retention actually persists for several days, meaning that even after the patient might be symptomatically improved, renal blood flow does not return to normal. And so in this case, which clearly demonstrates a dilated pelvis, we actually see this nephrogram persist. This mag scan was then repeated, and now about 3 months after the initial presentation, and you can actually see that the patient has fairly good renal function by comparison, so still at 30%, This patient ultimately underwent a pyeloplasty, and these are the post-pyeloplasty images demonstrating a very good drainage with a T1/2 now of 4 minutes following the pyeloplasty. How do we assess differential renal function? Well, luckily, it's fairly easy because once you have drawn the region of interest around the kidney, the computer calculates the contribution to total renal function coming from each of the 2 regions of interest, and then provides a percentage of that total. In most cases, patients who are evaluated for renal function present with fairly good renal function that is stable over time. And thankfully, renal functional loss during follow-up is quite rare, although it does sort of happen. You see here a patient who was lost to follow-up for approximately 20 months and returns with a significant drop in renal function. One of the things that I would call your attention to here is how we draw the regions of interest for determination also of renal function. The regions of interest are drawn very tightly right around the kidney parenchyma here, and background subtraction also needs to be drawn very closely around the same kidney, and it's very important to make sure that the background subtraction that is being drawn by the technologist doesn't bleed outside of the body. You need to make sure that the background subtraction is actually subtracting the background as opposed to subtracting the surrounding air. In very rare cases, you actually have a complete drop in renal function, and that is exceedingly rare. Interpretation of the diuresis half-time. This paper by Dr. Connolly out of Boston actually shows an interesting and an important point. And this is one of the reasons why people in various institutions, I think, have derided the reliability of diuresis renography. The shape that Dr. Connolly is demonstrating here has multiple phases, and it is not a surprise that if one takes this slope here as comparison to this slope here, 2 different methods, you're going to get 2 completely different diuresis half-times, this one being much faster than this time. But that doesn't tell the entire story. Remember that we actually have these half-times that were categorized by Evan Cass back in the 1980s. But these half-times, or these cutoffs, were valid for adults and older symptomatic children, but not for asymptomatic neonates and infants. And they probably should not be used in isolation, but should be taken into consideration along with the shape of the curve. So let's talk a little bit more about the shape of the drainage curve. In this example here at the top, we have a clear example of what we would call a biphasic curve. At the beginning, you have quite brisk drainage, and you see the tracer exiting the collecting system. But at a certain point, you have no further drainage. Drainage actually stops. So what's happening here? And what's happening down here? Where actually it looks like the drainage curve is rising after an initial fall. Well, we would posit that what's happening is a flow-dependent obstruction. The kidney, as it begins to drain, is actually becoming more distended. The renal pelvis becoming more and more full with the stimulation of furosemide. Once you get to an inflection point right here, the renal pelvis has become so distended that a conformational change at the UPJ occurs, and there is no further drainage that can actually happen. You have a flow-dependent obstruction. Flow is brisk during low flow states, or when the flow of urine now exceeds the capacity of the UPJ to conduct that flow, flow ceases. And this is the obstructive phase. And you have to be very careful about these kind of scenarios, because you can see here that if one were to rely on the report alone, the report would suggest a T1/2 of 13 minutes here and a T1/2 of 6 minutes here, which would be well within Evan-Cass's ranges. But that's not the whole story. Here we have 3 successive renal scans on the same patient when they were 5 weeks, 9 months, and 1 year later. And you can see here where you have a T1/2 for the early phase at 7 minutes, again in the second one. But notice also that the residual tracer actually is increasing. And by the time the child is 1 year old, now you have a flat curve. So I would have you all really think about this curve as being a dynamic, or a representation of a dynamic process. And please don't just concentrate on the T1/2, which is being presented to you by a computer. But what about clearance at 30 minutes? And what about this gravity-assisted drainage that we discussed previously? Well, we actually we looked at this. And what we found was that gravity-assisted drainage was more predictive than T1/2. This is the initial T1/2 in 2 patient groups before and after surgery. And what we found was that the T1/2 did change, so in follow-up, but the T1/2s were not very different between patients who underwent pyeloplasties and those who did not undergo pyeloplasties. Similarly, the clearance after 30 minutes was not very different between the patients who underwent pyeloplasties and the patients who did not undergo pyeloplasties. However, you look here, the drainage in the upright position is actually very different between patients who did and did not undergo pyeloplasties. The patients who underwent pyeloplasties had a much lower clearance in the upright position than patients who did not undergo pyeloplasties. So we would posit that gravity-assisted drainage may actually be a stronger predictive variable than the diuresis half-time for asymptomatic neonates. We performed ROC analysis, and the ROC analysis bore that to be true, that clearance in the upright position was the stronger of the 3 variables. We further extended this work by using a machine learning approach to look at the shape of the curve. And on the left, what you see here is a representative diuresis renogram curve. And these are all of the data points that were extracted by the computer to look at which one or which ones were predictive of obstruction. And one of the things that we found was that the machine learning, which takes into account not just the half-time and the clearance and the upright clearance, but also the shape of the curve, ended up being the most accurate, suggesting that perhaps diuresis renography would be improved by having all results analyzed by artificial intelligence rather than simply by 1 or 2 isolated variables. Our data, which we previously presented, shows that the ROC analysis for machine learning approached an accuracy overall of close to 96%. What about using this in certain select clinical scenarios? Well, one of the things that I do want to address is how we use this in cases of prenatal hydronephrosis. We actually performed a retrospective review of all cases of grade 3 to 4 hydronephrosis, and we found that worsening drainage could be identified over serial diuresis renograms, which we used as an indication for surgical intervention. And in none of those patients who continued on our protocol did we see a loss of renal function. In a small percentage of cases, did we perform immediate surgery because of poor renal function or flat or rising curves. Recall also the data that I initially presented from Mr. Ransley and Dr. Holmesy, which demonstrated very similar results to ours. There was, however, a group of children who had indeterminate half times. These are half times that did not necessarily correspond to a very prompt drainage. And when we followed them over time, we actually found that a very small percentage of them underwent surgical correction, most of these being patients with grade 4 hydronephrosis and a small minority of patients having grade 3 hydronephrosis. It's important to note that some have criticized the use of diuresis renography in the neonate, but the neonate has sufficient ability to extract the radiotracer and respond to Lasix. And it's because of this normal response to Lasix that MAG3 scans can actually be performed in infants as young as under a month of age. Lastly, how do we use this to look at obstruction before and after pyeloplasty? Well, a long time ago, we actually did a retrospective review looking at our use of diuresis renography at 3 months and 1 year following pyeloplasty. And we determined that when a diuresis renal scan performed at 3 months demonstrated a very prompt diuresis half times as compared to the preoperative values, that none of those patients required further intervention, and actually that obviated the need for the second MAG scan. So based on these findings, we have in our practice relied heavily on a MAG scan performed postoperatively, now at about 6 to 8 weeks after surgery. And if it demonstrates stable renal function and prompt drainage, then we can be fairly certain that that patient requires no further intervention. For symptomatic cases, the renal scan actually is quite useful, particularly for patients who have a Dietz crisis. Acute obstruction due to excessive hydration or diuresis, which is equivalent to beer drinker's kidney in adults. In this example, we actually see a patient who has symmetric renal function and is being evaluated for intermittent abdominal pain and hydronephrosis. In this case, the patient demonstrates actually reasonable early spontaneous drainage and is therefore administered the Lasix. Here you have the Lasix-induced diuresis, and over time, one actually sees cortical retention occurring. And that corresponds to the rise here. We have other cases that we have reported on, which have shown very similar results. I would have you consider using the cortical retention and diuresis renal scan when patients present with intermittent abdominal pain. In this case here, we have a patient who has actually a fairly minimal hydronephrosis who had presented with suspected Dietz crisis. And in fact, when we initially imaged that patient, we actually got a very good diuresis half time. But the patient then returned in a moment of crisis, and we were able to actually capture the fact that this is indeed intermittent obstruction. And this time they were actually having pain, and this time they were not having pain. And one final point, which is that reflux and obstruction can coexist. And so MAG scans sometimes need to be obtained in concert with avoiding cystourethograms. And when that is required, we will generally perform both studies on the same day in order for the infant to be catheterized only once. And they go in rapid succession from fluoroscopy directly to the nuclear medicine department for the complementary studies. In this interesting case here, you can actually see where the patient actually underwent a VCUG. And during the VCUG, the contrast enters into the dilated collecting system. At this point, we already knew that the patient had significant mismatch between the amount of renal pelvic dilatation and the ureteral dilatation on that side. And so he was already set up for a MAG scan, and then underwent his MAG scan immediately thereafter, and actually found that he did have coincidental UPJ obstruction on the right side. I want to just take a moment to acknowledge my three mentors. Now that I'm entering into my 19th year in practice, I reflect on all of the interesting things that I've seen over the last 19 years, and none of those things could have come to me without these three great gentlemen. So I'm grateful for the opportunity to talk to you all about the diuresis renography, and happy to take questions at this point. So I see the questions. There are 4 questions here. So taking them the order that they came in, will you comment on fine points of drawing the ROI for determining the split function? The drawing of the ROI is something that actually requires great care and a reasonably steady hand. The nuclear technologists that are performing these studies make sure that they magnify their images so that their ROIs are as close to the renal border as possible. Sometimes the nuclear medicine physicians who read the studies will disagree with the technologists. They do a quality control of the regions of interest, both of the kidney as well as the regions of interest for the background subtraction. And if they disagree with how the ROIs were obtained, they will actually have the technologists go back and redraw those ROIs and then redo all of the calculations. Will you please comment on general anesthesia and how it affects MAG-3 results? This is a very good question, because we came upon this actually somewhat serendipitously a few years ago when our radiology department was interested in minimizing the invasiveness of procedures that required catheterization in particular. And they began offering patients who were to undergo invasive procedures sedation. And we were not really aware of this, and we initially had no problem with it, but the patients, of course, received NPO orders and would come in, having been NPO for 6 to 8 hours prior to the sedation event. And then they were sedated and got their IV fluids. And we started seeing patients who had very abnormal drainage parameters. One of the quality control things that our nuclear medicine department also does is they record the amount of IV fluids administered, and they generally administer 2/3 of the IV fluids that they expect to deliver prior to the study. And then they also measure the amount of urine which is either spontaneously voided or is drained via the indwelling catheter. And we started to see a significant mismatch between the administered fluids and the drained amount, the voided amount, suggesting that the patients were coming so dehydrated that even the pre-hydration that they were receiving was insufficient to catch up. And as a result, there was a sufficiently decreased renal blood flow, and that caused prolongation of the half time. So we have moved away from offering general anesthesia for the vast majority of our patients for that reason. I received another question about, do you follow a top-down or a down-top approach? So that question is, I guess, germane to the evaluation of a febrile urinary tract infection. And now that there are 8 of us in practice, I would say that we don't all follow the same approach. Personally speaking, I do follow and believe in the top-down approach. Of course, probably most of the audience knows that we are heavily reliant on nuclear renography in our institution, and we have a fairly big experience with that. And so the combination of having access to excellent nuclear renography, as well as some very good data out of Sweden, have really made me comfortable with the top-down approach for infants and young children with febrile urinary tract infection. For those who are joining us who don't understand what the top-down approach is, that it is reliance on a DMSA scan first, and a VCUG is obtained in children who demonstrate abnormalities on the DMSA scan. Excuse me. Do you use a Foley catheterization for voiding? We use a feeding tube, not a Foley catheter, because we don't want the balloon to cause significant bladder discomfort. We feel that a feeding tube is sufficient. Thank you for those of you who are actually tuning in from Ecuador. Espero que todos estén bien y estoy preocupado de ustedes. How do you interpret the reported hyperfunction in obstructed renal units? That's an excellent question, and I don't understand why hyperfunction exists. It definitely does exist, but the embryological and the pathophysiological mechanisms for hyperfunction, I think, eludes all of us. In what clinical scenario would you suspect a concomitant VUR and UPJ that you would obtain both studies for the same day? I alluded to that when I was reviewing that one case, which is if you see ureteral dilatation and a dilated renal pelvis, but the two degrees of dilatation are disproportionate. So you see much more dilation of the renal pelvis than you do of the ureter, then you should suspect actually that you have obstruction at the UPJ and perhaps either obstruction at the UVJ, although obstruction at 2 levels would be exceedingly rare. So most commonly, the abnormality would be reflux. The question is do you use MAG3? Yes, we use MAG3. There's a question about when you mention flow pressure dependent drainage, do those curves correlate at all to the underlying pathology of UPJ obstruction, intrinsic versus extrinsic? And I would say, yes, they do. I mean, when we see flow dependent changes which are suggested by the biphasic curve, and we operate on those kids, they all have narrowed, generally they have all intrinsic obstruction because this is infant UPJ obstruction, which is generally intrinsic. Do you order a post-pyeloplasty MAG3 routinely? I do. The reason why I do is because post-operative obstruction, so iatrogenic obstruction or a complication it acts differently than preoperative obstruction. So, as I alluded to, the likelihood of seeing significant drop in renal function during longitudinal follow-up is exceedingly rare, thankfully. The cases that we have seen where function has decreased are really cases that were lost to follow-up for 1 or more years. So when we see the most significant drop in function, it has been when a pyeloplasty has been performed and we have had a bad result. And so we would say that why wait to get the definitive test to look for function and drainage? In our patients, we would prefer to know that everything is well or not well at about 6 to 8 weeks after the pyeloplasty. And so that's the reason why, well, particularly Gil, Rushton, and I have continued to use MAG-3 scans postoperatively. Do you order a MAG-3 study for all patients? No, I do not. I'm very selective with using MAG scans. I would obtain a MAG scan for a patient with grade 3 hydronephrosis with dilated calyces and a dilated renal pelvis, and definitely for cases with grade 4. Do you think an ultrasound is enough to diagnose UPJ obstruction? Definitely not. There's another question about supernormal differential function, and I agree it exists. I have no idea why, but it is a very interesting thing. In terms of the specific protocol for VCUGs, well, the VCUG, obviously the patient is catheterized. We generally do at least 2 filling cycles for the VCUG. We do not use Foley catheters because of the concern, again, that the balloon may occlude the bladder neck. But we do use Foley catheters if the ultrasound suggests ureteral ectopia, particularly in the female. And the reason for that is that a feeding tube may be inadvertently passed up the distal ureter, and a Foley catheter, though, will not pass up the distal portion of the ectopic ureter in those cases. Which is more informative for description of split renal function, split percentage, or split GFR? Well, if one could obtain a split GFR, that probably is the most sensitive, but for practical purposes, obtaining a split percentage of the renal function using a diuresis renal scan is certainly the easiest way to go. We are not using general anesthesia for these studies, so how do we manage an uncooperative 2-year-old? We have our ways. Oftentimes, what we'll do is we'll have iPads and all sorts of mechanisms to distract the child, and our technologists have a lot of experience with doing this in kids of all ages, and I don't know, they're miracle workers, and I couldn't do the job that I do without them. Okay. Sí, gracias. Mi español es excelente porque mi mami es del Ecuador. In my country, having the differential when there's double collecting systems. Yeah, well, so obtaining a differential renal function from duplicated collecting systems is it is a technical challenge which is reliant upon a very good technologist to draw those regions of interest. Dr. Maj will jokingly say, well, what do you want the function of the upper and the lower pole to be? Because I can give you any function that you want depending on how I draw that. So what you really need to do is you need to look at the early phases, the first and second minutes where you have the cortical phases, and generally you'll be able to see where the median bar is that defines the upper and the lower pole, and then you very carefully draw your ROIs around that. So cortical transit is the transit of the isotope through the parenchyma and into the collecting system, or the nephron. So the cortical transit phase is the time that it basically takes to get into the glomerulus and the collecting tubules. And part of that for MAG3 is dependent upon secretion of the MAG into the tubule itself. So that's actually it's an active process, as opposed to other nucleotides which could be used, for instance, like DTPA, which is much more heavily filtered as opposed to secreted. So processes which are secreted or active processes depend more on active renal physiology. And so anything that perturbs renal physiology, such as dehydration, then has a greater effect on the cortical transit of those kind of tracers. Oh, what is your cutoff for nephrectomy? Well, personally, my cutoff for nephrectomy is 12%. Sometimes I will entertain a pyeloplasty, but tell the parents that, look, if this pyeloplasty is very difficult for whatever reason, those reasons generally being like giant hydronephrosis where the renal pelvis crosses the midline, or hydronephrosis in a pelvic kidney where it's a very bizarre anatomy and the renal pelvis is malrotated, then I would say I will entertain doing a pyeloplasty if I can guarantee you a high likelihood of success. But if technically it is it's not going to be a guaranteed pyeloplasty, then if there's 10 or 12%, then I would just remove that. Do you physically restrain toddlers on a papoose board? Yes. Do you allow babies to feed while supine during the study? Usually the babies, actually, we will inject them with the tracer, and we do allow them to feed, and then they will fall off to sleep, and then we actually can do the remainder of the study. For nephrectomy, 12% without symptoms or with recurrent infections and hypertension. So I would say, if I think I understand that, so what would be my indication for the nephrectomy? It's 12% is 12%. So irrespective of what other signs or symptoms may be presenting with this diminished renal function, to me it's 12% is 12%. So I would try to repair that. But if I think that, or if I thought that it was not going to be a successful repair, then I would just go ahead and remove it, because a 12% functioning kidney is really not going to contribute that much. What is the correlation of renal plasma flow and GFR? Well, GFR is basically just filtration across the glomerulus, and which is essentially equal to renal plasma flow. The two are very, very tightly linked. Do I consider paradoxical hyperfunction as an obstructive sign? I do not. I rely on the diuresis parameters to diagnose obstruction. In patients that have obstruction, we have paradoxically seen hyperfunction, but I would not use hyperfunction as the measure of obstruction. So at this point, I guess it is 7:58 here on the East Coast, 4:58 on the West Coast. It's been a pleasure to participate in this, and I'd like to thank Dr. Kopp for making this possible, and I really encourage you to make this a long-standing part of the pediatric urology community. And for those of you who tuned in from far away, particularly from Colombia and Ecuador, my heart goes out to all of you down south. Half of me is from South America, and I like to say it's the better half. So with that, I wish everybody a really good night and stay safe, and look forward to seeing you again in the future.